This conference will now be recorded.
Assalamu alaikum. How are you, everyone? Um, Welcome to the antenatal guideline key points, okay, or summary today. Hopefully that you will find it useful, inshallah. For my friend who started their journey a while ago, and they are familiar with the old one, the antenatal care. Okay, so I just want to say that there is no much change. Okay, so the changes is in the risk of stillbirth, mortality, emphasize the role of mental health screening and psychiatric screening for the lady, partner support as well during the antenatal care journey. Okay, so the things would be easy for you, okay, to review this guideline. The good thing about this guideline, it's very easy, straightforward, but it has all the framework or the base, or I would say this is the father of all guidelines, really, in the antenatal care. Okay, so they give you the framework, the care in the NHS, okay, and the journey of a pregnant woman through her antenatal care. Okay, so this is the first thing you see here. This is the first figure. This is actually comes from the NICE algorithm. Okay, the NICE pathway. It's simplified way to understand what this guideline speak about. Okay, so here they have started with the pregnant woman journey. Okay, managing nausea and vomiting if it is present. Okay, and how are you going to reassure the lady? What is the first line of management we offer them? Then the discussion and information provided at the booking appointment, and this is all, as we said, okay, just the regarding the safeguarding issues, regarding the woman mental health partners, okay, and how is the plan will go throughout the pregnancy antenatal journey. Okay, then taking the woman history and initial measurement and blood test. This is very important in the single best answer questions. Okay, and I think this guideline is super important for both part 1, 2, and 3 as well. Assessing risk of preeclampsia and monitoring blood pressure. This is very important because we will do that at booking and at each every appointment at the antenatal visit, especially if it is a face-to-face visit. Screening programs, assessing risk of VTE. Okay, everyone is familiar with the guidelines, the GTG, reducing the risk of VTE in pregnancy. Okay, the big guideline. So this will be in line with this guideline. So what we will do for the VTE risk assessment, the antenatal care, when is the time we do the assessment? Okay, so this is only an introduction for that. Gestational diabetes, same thing, the principles, which woman you will advise as soon as possible, monitoring of the blood sugar or a GTG at the time of booking, or which woman you will screen at the from 24 to 28 by the OGTT. Okay, so here you will get this information, and also the risk of fetal growth restriction, the small for gestational age, and also what is the management for this and pathway. So let me go with you after assessment of all the risk, and this will happen at the first contact with the lady and be repeated at the second trimester. Okay, so what we offer for every lady comes to us. Okay, there is a package we offer them. The package is screening test, okay, for infectious disease, for hereditary or carrier status for sickle cell anemia and thalassemia. Okay, and we will discuss in detail which woman will go through this screening, the detailed one, and which woman will not. Okay, and the Down syndrome screening, which will be discussed in separate from this guideline. Another problem this guideline just mentioned is the managing unexplained vaginal bleeding after 13 weeks. This is unexplained, does not relate to low-lying placenta, okay, or placenta previa. This is only unexplained, so we don't know the cause why the woman is having antepartum hemorrhage, okay, or she has some bleeding even per vagina. Some women will have that and then it will settle. They will never have in the future any episodes, and it will go unexplained without identifying causes. Then he will mention he will come to some common problems like heart pain, like pelvic girdle pain. Okay, so it's all a clinic thing. Okay, then they will come to the monitoring of fetal growth or discussion information provided to the woman, blood test at the 28, and anti-D prophylaxis for rhesus negative woman. He will get some information about breech, but breech will be again discussed in details in the management of labor. And for the prolonged pregnancy, he would just give you some advices there. Okay, so go to the overview and the important points which can come in the single best answer for all of you guys. Okay, so it's when the woman should have her first booking visit. The first booking visit with her midwife or with the GP as a low risk woman, okay, will be by the 10 weeks of gestation. So it's advised to be completed by the 10 week of gestation. And if the woman presented late, okay, first presentation in her pregnancy was late than 9 weeks, okay, so we will try as much as possible to make her appointment within 2 weeks. Okay, of course, 2 weeks, this is a quick appointment for the NHS appointment system. Okay, so what is the plan? How many antenatal visits will the woman will have? In primi gravida, the low risk woman will have at least 10 visits. This is the plan. For a multipara woman, we will have 7 appointments. Okay, so this is different from any woman who had high risk for some conditions, but generally speaking, for the multigravida, it's 7. For the primi, it's 10. Okay, it can come as a single best answer question ask you. What is the thing that will be discussed in this booking visit? Of course, that will include every information about the lady, including with whom she's living with, including information about her partner, including information about her mental health status, and including information about domestic abuse, okay, or violence in a sensitive way. Can be happen at the first chance the woman is alone, so you can ask her about the domestic violence or the domestic abuse. Also, you can ask for the FGM, especially if the lady is coming from a high risk area, okay, where they practice the FGM. Okay, and it's very important that this will be mentioned in the woman files, okay, and will be documented. There is some ladies will be identified to be at risk and they will be managed, okay, with the help of the social care. Which woman not at medical risk? Here they speak about the ladies with issues, okay? They have some issues like substance abuse, okay, addict, or teenager who is pregnant, or a woman who had domestic abuse at home. If the woman is recent migrant, asylum seeker, or a refugee, or any woman who had a difficulty reading or speaking English. By the way, guys, because this is the site of your exam questions, if the lady identified to be having difficulty reading or speaking English, what you will do for her? Do you accept that her partner be her translator or one of the family? No, it shouldn't be one of the family or the partner. It must be a professional interpreter. Okay, so the professional interpreter will be attending the consultation, or even you can arrange, at least arrange it by the phone. Okay, but it is not allowed, okay, to take the family member or the friend as a translator, because they can. I'm sorry. Please, everyone, make sure that your mics are muted. Thank you. So every woman, when she come, because you are screening for the domestic abuse or anything, okay, FGM, or her own wishes, okay. So yes, we advise the partners or to attend as much as we can, but for the woman who had difficulty reading or speaking English, a professional interpreter must be there, and this is a question in the single best answers that appear in your exam. Then we'll come to the new part. This is a new part in this guideline. Okay, so the new part in this guideline actually speak about the risk of mortality and risk of stillbirth in the pregnant woman. Okay, so they have identified some high risk groups, okay, for complication during pregnancy. So according to the 2020 maternity and morbidity and mortality report, women and babies from a minority ethnic background and those who live in deprived area have an increased risk of death and may need closer monitoring and additional support. Okay, that this support will include the social service as well if needed. Okay, so can anybody of you tell me, guys, when we have increased risk of complication mentioned before in the minority groups, in the PAME, Black and minority ethnic background group? Yes, excellent, Dr. Manal, it's in the COVID. Yes, so they are even at higher risk in COVID. And in COVID, they cannot understand the relation, maybe a genetic, maybe lower vitamin D level, okay, but even in the antenatal care, they have found they are at higher risk. Okay, so when they compare them to white women, okay, the risk of maternal death during pregnancy and up to 6 weeks postpartum is 4 times higher in Black women. Okay, so this can come as a single best answer question. 4 times higher in the Black woman, and the exact number is 34 per 100,000. 3 times higher in women with mixed ethnic background other than Black women. 2 times higher in Asian women. Okay, so they have found that in white women the risk is 8 in 100,000. In Black women the risk is 4 doubles, it's 34 in 100,000. 3 times higher in mixed group, ethnicity groups, and in Asian women it is doubled, 2 times higher, and it's the exact number is 15. Okay, and this does not include Chinese women. Compared to white babies, this is the risk of stillbirth to the baby. Okay, what is the risk of stillbirth in the babies when they in this study in the NICE? It's 34 per 10,000. The stillbirth rate is more than twice in Black babies. So unfortunately, even Black babies are at higher of stillbirth, and the exact number is 74 per 10,000. So the neonatal death is by 10,000. The maternal death is 100,000. Around 50% higher in Asian babies. Okay, so guys, in easy to remember this, it's written compared to white woman 432, 432, 4 for the Black woman, 3 for the mixed ethnic groups, 2 for the Asian ladies, and for the babies the risk of stillbirth comes in 10,000, and the baseline For the white babies is 34. For the black babies is double or more than double even. It's 74, and around 50% higher in Asian babies, which the exact number is 53 per 10,000. They have found also not the ethnic group, but they have found even living in deprived areas or poor areas, okay, they have risk more than 2.5 times more likely to die compared to women living in the least deprived areas. Okay, so even when they look to where they live, they have found that deprived area has 2.5 higher risk, okay, than those who are living in the least deprived area. Okay, the stillbirth rate increase according to the level of deprivation as well. Okay, so even in babies, they have found that it's almost doubled, 47 in 10,000 in deprived area. Okay, even if they are white, but living in deprived area is separate risk. When they compare it to the least deprived, it's 26. Okay, so guys, you have to look to this books, okay, as this is the new numbers has been mentioned in this update of the guideline. Okay, and as we know the game, we have to be aware of the updates. Whenever we have updates, we have to be aware of it. Dr. Sanya, if you are going for September exam, it is unlikely that this numbers comes to you. But for January people, yes, I advise they revise this. If the woman or her partner smokes, what we will advise them, stop smoking, right? What you will do, you will refer them to the NHS Stop Smoking service. Okay, so simply this is the advice, explaining the risk of smoking during pregnancy to them. What are the examination and the investigation will be offered at the first appointment? Okay, so first you will check the BMI of the lady. Obese ladies are increased risk in pregnancy, right? Is it correct? Yes, this is correct. You offer them a blood test to check for the full blood count. This is for everyone. Blood group and recess D status. Okay, so it's very important at the booking visit as well. What else you will offer them? The booking investigations. You are offering them some investigation as a screening for infections. So, screening for infections including HIV, syphilis, and hepatitis B. The question can come in the single best answer and ask you, is hepatitis C is part of the routine booking investigation? No, it's not correct. Not hepatitis C. NHS Sickle Cell and Thalassemia Screening Program, okay, will be applied. Okay, so because I love this NHS Sickle Cell and Thalassemia Screening Program because it's very well written actually, and it explains all the conditions that comes in exam, by the way. Okay, so I'm so happy that even the NICE in its update has already referred to them, and he just put the link, okay, for you to revise them. Okay, and I'm going with you through those screening program, explaining them. Then the NHS fetal anomaly screening program. So I will be stopping here, guys, okay, because both of them need a detailed discussion. Okay, so the question number 1 says, are we screening every woman for thalassemia or not? True or false? for thalassemia? Okay. Okay, so all actually, no, Dr. Sarah. This is good point that I asked it, okay? So, guys, the answer is yes. Yes, we offer screening for all pregnant women, okay, in England, a blood test to find out if they have thalassemia or not. You know what is this blood test? It's a simple and routine blood test for the thalassemia. Yes, simply, okay, the full blood count, okay, which is known in other countries as the CBC, okay. So in the by the full blood count, you will get the mean corpuscular hemoglobin, the MCH, and if it is less than 27, okay, so this woman will need further testing to make sure if she has the thalassemia trait or she's a carrier for the thalassemia or not. What is the next step? What is the next step testing called? Hopefully, guys, you can see here the MCH, okay, the mean corpuscular hemoglobin. The MCH, when it is less than 27 picogram, okay, because of course it's RBC, so it's by the picogram. Then what is the next step? The next step, you want to identify, okay, the high risk. You want a diagnosis now. You will do HBLC. Okay. So what is the HBLC? It is referred to answers, guys. Just I want to make sure that you are here. Yes, high performance liquid chromatography. Yes. Okay, guys. So the HBLC, okay, will identify if it is normal hemoglobin or if it is abnormal hemoglobin. Okay, so what is the trigger in thalassemia screening? In thalassemia screening, the trigger is MCH less than 27 picogram. Okay, so this is a very famous question to be asked, guys. So all pregnant women, okay. I hope before you guys put the question, okay, give me 1 second to complete the sentence. Thank you. That will be appreciated. For the thalassemia, all pregnant women will be screened by just looking to their full blood count, and if they have the MCH low, less than 27, that will trigger the HBLC testing. Okay. For the sickle cell, it's the family questionnaire. Okay. So make it very easy to you because I will not be like, keeping the knowledge. This is the link of the NHS screening for the sickle cell and thalassemia. Information there, and this is the link that's found in the GTG. They advise you to refer to it, and found also in our notes, okay, for the hematology problems or blood disorders, and found, okay, in this guideline, I have put it there at the end as a recommended reading. So please have a read to that, and you will, I promise, you will enjoy the journey there. Okay, so what's written here? Screening for sickle cell and thalassemia, okay, as inherited blood disorders, and they are very famous. Okay, if you are a carrier of a sickle cell or thalassemia gene, you can pass this information written for the ladies, but it's very valuable for doctors as well. You can pass these genes to the baby, okay? All pregnant women in England are offered a blood test to find out if they carry the gene for thalassemia, okay? But we will do the family origin questionnaire for the sickle cell, okay? So which one you will start by the family origin questionnaire? Sickle cell or thalassemia? Yes, it is the sickle cell. Thalassemia, it's a routine. Everyone will have the full blood count. They will look to the MCH, okay, and they will look to the value of it. If it is less than 27, they will go to the hemoglobin, okay, the HPLC, identifying the hemoglobin type, okay. For the sickle cell, it is different. In the sickle cell, it is not offered to everyone. The sickle cell, we will ask the woman about the family origin, okay, which is called the family origin questionnaire. If the family origin questionnaire or the prevalence of the sickle cell are high from their way where they live, okay, we will offer them a test for the sickle cell screening. What is this test in the sickle cell? To identify the type of hemoglobin they carry. Yes, HPLC again. Yes, excellent. Okay, this is another famous question. So HPLC will be offered to identify a case of thalassemia if you find that the woman has MCH less than 27. Or it will be offered to identify a woman with sickle cell disease if she had family origin questionnaire. Okay, she's at high risk at the family origin questionnaire, right? So this is the test, guys, that will be offered. Okay, so the next step, if you identify that one of the parents is a carrier of the sickle cell or the thalassemia, may I ask about the mode of inheritance for these conditions? Is it autosomal dominant, autosomal recessive? Okay, so what will be the risk for the unborn baby? I can't tell because I need the other parent. I need the partner. I need her partner, the father of the baby, risk identification as well. So if the woman found to be a carrier for a condition, what you will do? Yes, it's very important screening for the partner. Yes, excellent. So it's very important to screen for the partner. Okay, so when you screen the partner, what are the chances? the chances that he is a carrier or not, right? Okay, so if you find that both parents are carriers, the very famous question that comes in the exam, if both parents are carrier, what are you going to do? You will count the risk, right? You will identify the risk. So the chances for the baby is that 1 in 4 will not have anything, will be completely healthy, not a carrier, not a disease. 2 in 4 will be identified as a carrier. 1 in 4 will have the chance of getting the disease. Very famous single best answer question, okay? And it's part of the council. So it's very important, okay? 1 in 4 are healthy, 1 in 4 diseased, 2 in 4 are carriers, okay? What if the lady is a carrier, but the partner is found to be healthy, not having the gene? If there is any risk for the baby, the unborn baby, to have the disease? No, it's 0. And this is another recall question, okay? So they will ask you, if the mother is a carrier of sickle cell disease, partner is healthy, so what are the chances that the baby will have the disease? Have the disease? It's 0, right? So nobody will have the disease because you will need a pair of genes, one from the partner, one from the mother. So if the partner is healthy, then nobody will get the disease. So what is the action? Now you have, you know, what are the chances, right? Now, if you find that one is carrier, the other one is healthy, there's no problem, okay? You will not be worried about the disease. But what if during pregnancy, because we speak here about the antenatal care, you find that both mother and father are carriers? What is the next step after you counted them about the risk? Yes, I was waiting for the cell-free fetal DNA. Cell-free fetal DNA, okay, is not the test. Because people tend to mix between prenatal diagnosis test and screening test. It's the invasive testing, it's the prenatal diagnostic testing. And the diagnostic test means invasive test. Okay? Diagnostic test mean invasive test. So what are the options of invasive testing? According to the gestational age, yes, excellent. It would be either CVS, if we speak about the first trimester, or if above 14 weeks, we will offer the amniocentesis, right? So if the lady have presented and been discovered during the first trimester, so we can offer them the CVS and it will be arranged accordingly, okay, from 11 to 14. Or if the lady is beyond the 14 weeks, we will arrange the amniocentesis, and the time for the amniocentesis, it's 15 weeks better, okay, to start from them. Okay, guys, so the steps of the diagnosis, it can be a simple equation. But I need every one of you now, okay, to write it down in a note by your own way, okay? Because this is the best way you keep a note in mind. I will tell you that, first of all, thalassemia or a sickle cell disease. Thalassemia pathway says MCH less than 27, go for HPLC. Okay? If the mother found to be positive, okay, means she is a carrier, identified as a carrier, please test the father. If you find that both father and mother are carriers, remember the risks, okay? 1 in 4, 1 in 4, or 2 or 4. 1 in 4 healthy, 1 in 4 have the disease, 2 in 4 will be carriers, okay? So if you have the chances that both are carriers, you will need to do further tests for the baby to identify if the baby is carrying the disease or not, okay? And this will be after counseling, extensive counseling with the parents. So if the mother agrees for the prenatal diagnostic testing, okay, we will perform it. Otherwise, if she does not agree, if she refuses, then we will only have test after delivery, okay? The neonatal blood spot test, okay? That will define the baby, the newborn baby, if he is having the disease carrier or he's healthy, okay? So testing the baby is the only way. If the woman refused, test during antenatal, the fetal prenatal diagnosis. And it's not cell-free fetal DNA, okay? It's a common mistake. And actually, I don't know what is the source of this mistake, but it is not written in any reference, okay? If we speak about the screening of sickle cell disease, what is the screening of a sickle cell disease? You start by, for the sickle cell disease, family. Family, yes, origin questionnaire. If she is high prevalence, okay, then what we will do, we will offer test to identify which type of hemoglobin she has. The name of the test is the HPLC, right? Excellent. Okay, then if she been identified as a carrier, what you will do? After the HPLC, it is the same thing. Test the father, okay? Because we need a pair of genes to inherit this disease. So we need the father here, okay? So partner testing, right? So if the partner found to be healthy, nothing to be done. If the partner found to be a carrier, offer prenatal diagnostic testing, okay? Prenatal diagnostic testing will be offered to the lady. If she refused to perform the screening, can we force her? No. That will be the neonatal, yes, the neonatal diagnostic test after delivery. Okay, guys, so the very important point is in our job is to identify those ladies at risk, okay? Risk of infection, risk of Down syndrome, risk of sickle cell disease or thalassemia. Okay, so guys, what if the woman refused to do a screening test? Because this question also comes in exam. Like the very famous question comes in exams about the HIV testing, and they have their reasons. Okay, so the woman, she think that no, I don't want to be tested. So if I come to be positive, my partner will leave me, or I will be criticized. Everyone will know that I have HIV, so they will say I'm not having, you know, I'm not a good person, so I'm having maybe a relationship, or I'm a drug abuser or anything. So people will start to talk about her. Okay, so she will refuse. What's your job as a doctor if the patient refuses HIV testing? Can you force her to do that? Yes, so you will just explain to her, okay, the risk for the unborn baby, risk for herself, risk for the partner. Explain to her that the treatment is available and it's highly successful to reduce the risk of transmission of the disease to the neonate. Also, it's very important to receive a treatment for herself. Explain to her that all the information are confidential, okay, and nothing will be shared with anyone without her consent. Okay, so we will write down in the documentation and we will repeat again the same thing in the second trimester. Okay, so again at the second trimester we will offer her a second chance for testing. Okay, yes, and confidentiality of the test is very important. Okay, if she is found to be positive, this is another thing. Okay, if she is found to be positive, so this is a condition that will risk the life of the partner. So we are obligated by law to inform the partner about this risk. Okay, we will also counsel her, okay, before we inform or we notify the partner that he's at risk of HIV. Okay, so the confidentiality means we are keeping the woman confidentiality from the healthcare professional, from her family, okay, even from her GP. The woman can choose not to inform the GP about any information. Okay, so we are keeping the confidentiality at this level. But when another person is at risk, okay, so here we cannot, because it's something ethical, we cannot leave the other person in the relationship at risk of getting a life threatening infection like HIV without informing him. Okay, so it's very important. And also, careful guys, we will not, okay, ring the phone and say, hello, Mr. Husband, I would like to inform you that your wife is positive for HIV and she didn't tell you. Will you do that? Of course, no. So this option in exam, because this question will come to you in exam, possible because it appeared before so many times. Please choose any option that contain counsel the lady, inform her about the risk, tell her that you are obligated to notify the partner, okay? Or do arrangement. Why arrangement? Because you are going, okay, to put her at risk. So you don't know, maybe after this phone call or the letter that the wife, she has HIV positive, maybe he's going to beat her, maybe he's killing her. Okay, so even breaking the confidentiality, yes, This is a situation to breach the to break the confidentiality for the woman, but there is a pre-arrangement for this step. Okay, so even breaking the confidentiality would be arranged. Okay, guys? So be sensible in your choices when you read the option. Okay, look to what options you have, okay, and choose carefully. You know that you are going to inform the husband, but after extensive counseling to the lady and after arrangement with healthcare professionals. Also, maybe social service will be involved in this situation as well. If the woman found to have any sexually shared infection, what is the next step? She found to have one sexually shared infection. Yes, referral to the gum clinic, excellent. This is one step. Screening for other STIs, yes, excellent, Dr. Nairoz. Okay. Yes, they will do partner tracing in the gum clinic. They will arrange that. Excellent. Okay, so here one question. What if the lady found to have, for example, chlamydia, and she refused to tell her partner? Is that a cause for breaking the confidentiality of the patient? No, because this is a treatable condition, okay? Even it can go asymptomatic in men. So here, because we are we are weighting both risk and benefit, okay? So there is no imminent danger to the husband from a chlamydia infection, no life-threatening condition. So we will not break the confidentiality. And also we will still trying to counsel her, and we will tell her that we will send even anonymous notification, okay, for the husband. So it doesn't need to be like, or the partner. But anyway, this is comes in details in the legal problems, okay? But I just wanted to highlight these things because the scenarios comes in exam like that. They ask you about a lady at the booking visit and she refused the HIV testing. So what you will do if she refused the HIV testing, then only counseling and offer her document and offer her another testing, okay, another time to be tested in the second trimester. Maybe she changed her mind, okay? If found to be positive, this is another thing. Okay, guys, so the Down syndrome screening and the next step, because we are with the lady at her journey, she had already the booking visit, and at the booking visit we have all the information about her history, about her risk and everything, okay? So what is the routine thing we will be offering her? We have a routine scan between 11 plus 2 days to 11 weeks plus 2 days to 14 weeks plus 1, okay? This is the first ultrasound scan. In this first ultrasound scan, we will determine the gestational age, viability of the pregnancy, if it is a multiple pregnancy or a single-tone pregnancy, okay? And the woman should be counseled about the Down syndrome screening at that time. If she chooses, okay, if the woman chooses to have the screening, then we will measure the knuckle translucency and we will offer the blood test for the Down syndrome screening. And this is called the combined testing. So we offer the combined test for everyone, right? We will offer them the Down syndrome screening. But can we force them to do it? No. It's according to the lady if she chooses to have the Down syndrome screening or not. This is according to the patient wishes. So, the combined test, and we will come to in details in the Oh yes, sorry, this was interruption in the internet. I'm so sorry. Can you hear me guys now? Thank you very much. Okay, so we have stopped with the combined testing. So the combined test is a combination between the ultrasound and yes, biochemical testing, right? Okay, so what are the substances that will be tested in this case for the combined test? Very important to remember those because it will come in the exam and they will ask you. So you are going to measure the beta HCG plus, yes, pregnancy associated plasma protein A. Okay, so we will come to the quadruple test in a minute. Okay, so just we finish with the combined, then we go to the combined to the to the quadruple test. So guys, for the combined testing, it's a combination between again serum and ultrasound. Knuckle translucency best to be measured between 11 and 14, right? I'm sorry for the interruption of voice again. I'm so sorry, guys. So, guys, if the woman presented late in pregnancy, what are you going to offer her as a Down syndrome screening test? Late, that means she presented after 14 weeks. So now it is too late for the combined test. The next test will be advised is, yes, it is the quadruple test. And the quadruple test contain serum only, right? So we are only measuring the serum. What are the substances measured in the serum? It's a quadruple, so they are four. Alpha, beta, and IE, right? What is the alpha? Alpha is alpha fetoprotein. Beta is for beta HCG. I for the inhibin. E is for estriol, right? Yes, excellent. So the alpha beta IE is looking for which condition? Is it the Down syndrome only or Down syndrome plus Batau and Edward? The quadruple test is looking for mainly for the Down syndrome. Okay, so the quadruple test looking mainly for the Down syndrome. Okay, and this is very important part in our counseling. Okay, because guys, different tests has different sensitivity and specificity for detection, okay, of the conditions. Okay, I would like just to, I'm sorry, open another file. Yeah, this is the one. So which one is done routinely? The combined test done routinely and the quadruple test done routinely. The combined test, again, it's first trimester test based on the combining of knuckle translucency measurement with the free beta human chorionic gonadotropin, beta HCG, and pregnancy associated plasma protein A, PAPA, and we will put in the equation the maternal age. Okay, so which one has a PAPA and beta? It's the combined test plus the ultrasound. The quadruple test is a second trimester test based on measurement of alpha, beta, I, okay, E, the inhibin A and the E. There is no PAPA because I've just seen in the messages, okay, there is no PAPA in the quadruple test, guys. It's alpha, beta, I, E, okay? Try to remember it that this way. Even myself, I remember it only this way. So when we offer the woman information about the Down syndrome screening, we have to inform them about the possibilities of the test. Okay, so if the test found to give us high risk for the Down syndrome, and the high risk is identified as risk of 1 in 150. Okay, so what is the next step for us? If the woman found to have high risk, okay, when we say screening test means we identify either the lady is a high risk or a low risk, right? Is it a yes or no test? No, it's not a yes or no test. So what are the diagnostic tests we have? Diagnostic test. The diagnostic test we have is a CVS or the aminocentesis. Okay, so we have, guys, here women at high risk. Okay, so we either offer her, according to the gestational age, a CVS, which is taking sample from the placenta under ultrasound guidance, and we have to inform her about the risk of miscarriage that's included, which is 1 to 2 in 100. And they found that losing the baby, the possibility of losing the baby 1 in 1% is high for them. Okay, so they may refuse. The other test is the aminocentesis. Aminocentesis, that's again based on the gestational age, better to be done after 15 weeks of pregnancy. And this will include taking a small sample of amniotic fluid that surrounds the baby in the uterus under ultrasound guidance. The aminocentesis will have still a risk of miscarriage. This risk is a little bit lower than the CVS, but still around 1%. Okay, so this risk of the amniosynthesis is still there. So even if the woman refused, what is the next step to be done? Yes, so we now can offer them non-invasive prenatal testing. Okay, why we would say that? Because simply now it is covered by the NHS. Okay, because before that it was, scientists, doctors are trying, to advocate the use of the non-invasive prenatal testing, but recently it has been covered by the NHS because it's an expensive test. Okay, so now we can offer it to the woman. So the woman can have in our counseling, if she is identified as a high risk for the Down syndrome after the screening test, she can have either the diagnostic test or the non-invasive prenatal testing, okay, which is based, okay, on the technology of identifying the cell-free fetal DNA in the maternal circulation. Okay, so the cell-free fetal DNA will be offered for a high risk ladies. Okay, so again, I will advise you to go to the same link offered by the NICE guideline about Down syndrome, Edwards syndrome, and Patau syndrome screening. Okay, so this is identification or definition of the testing. Okay, then what if the woman had high risk, okay, for the Down syndrome? So this is a possible result, lower chances result if the screening test show with that the chance of having a baby with Down syndrome, Edward or Patau syndrome is lower than 1 in 150. This is a lower chance result, more than 95% out of 95 women out of 100. Screening test result will be lower chance. So a lower chance result test does not mean that there is no chance of the baby to have Down syndrome, Edwards or Patau. But if the woman identified from the first as a higher chance result, okay, so what is the management in this case? If the woman is identified to have a higher chance, okay, the further test to be offered is either to have the non-invasive prenatal testing as a blood test, okay, or to have diagnostic tests like the amniosynthesis or the chorionic villus sampling, okay? And if she refused the invasive, offer the non-invasive prenatal testing. If the woman has been offered, if found to have high risk of the condition, okay, so we will go to the diagnostic test or the non-invasive prenatal testing. So guys, easy till now? The next step in our discussion, okay, is discussion of some risk and numbers. And it's very important as well for the exam. So I need you to be fresh and focus with me, because those used to come as a single best answer questions for part 1 and 2, and to come as eMRCOG question for part 2 as well. Forget about them, Dr. Aya. Did I mention them? I didn't mention them, so not important for you. This is for reading, okay? When you have time, go and read, relax and read more. But for the exam purpose, what's offered in the UK as a screening test is only the quadruple test and the combined testing. Okay, guys, so this is risk of Down syndrome associated with maternal age. This is a background risk. Okay, so those numbers is important for you. I need you to remember that for a woman who had 40 years, we will call them advanced maternal age. What is their background risk for Down syndrome? Their background risk for Down syndrome is 1 in 100. Very important single best answer. Yes, we offer a screening test for every woman, regardless her age. So even if you have a 20 years old lady pregnant with background risk 1 in 1,500, we still offer her the screening test. Yes, we offer for every pregnant woman Down syndrome screening according to their gestational age. So Dr. Rabaa, the woman can accept or refuse. This is her own right. But we speak here theoretically speaking, okay, about the background risk of Down syndrome with maternal age. Okay. For a woman who has 30 years, what is the background risk? 1 in 800. For a woman 35, the background risk is 1 in 270. For a woman who is 40 is 1 in 100. For a woman who is even 45 or older than that, the risk is more than 1 in 50, so 2%. Very high risk, right? Can we depend only on the maternal age to give us the chances or the possibilities of Down syndrome? You think it's accurate? No, not very accurate. Yes, it's only 30%. So this is a background risk, theoretically speaking, but 30% only can give us, the estimation of risk. So that's why we don't depend on them. We don't depend only on that background risk by age. The next table is very important. The next table is discussing with you guys the accuracy of different tests for screening for Down syndrome. So if you use a maternal age alone, the detection rate will be 30% and false positive rate is 5%. Okay, guys? So this is the accuracy of the method of screening. If you just depend on the maternal age, the accuracy will be 30%. For the second trimester serum biochemistry, okay? For the quadruple test, because this is the one done, quadruple test that include alpha-fetoprotein, beta-HCG, inhibin, and unconjugated E3 estrogen. Okay, so the detection rate is 70 to 75, and the false positive is 5%. Dr. Nairoz, dear friends, you cannot forget this table. Okay, so among these numbers, 3 questions in the eMRCOG came in exam before, and it's repeated in the single best answers. So careful with this table, it's very important. For the combined test, the detection rate is 90%. So even if I ask you guys between the screening testing of the first trimester combined test or the second trimester quadruple test, which one is more accurate? The combined, right? Yes, even the combined come as a single best answer question, and it's repeated one as well. He's asked you about the detection rate of the combined test for Down syndrome. So it's 90%. We don't use the integrated one. The cell-free fetal DNA, which is the non-invasive prenatal testing, has a detection rate of how much? 99%. So it is very accurate, right? What about the false positive rate? It's 0.1% has false positive rate. So if I give you a question now, single best answer question about the non-invasive prenatal testing or the cell-free fetal DNA test for Down syndrome, detection rate is 99%. False positive rate is 0.1%. The recall question about the combined test, it's 90%. Maternal age, a recall question as well, 30%. Quadruple test, 70 to 75. And remember, the false positive rate in all the testing was 5%. So even they can give you positive result, but it's found to be false in 5% of cases. Okay, guys, so this table is very important. For my friend, another question asking about what is the difference between non-invasive prenatal testing and non-invasive prenatal diagnosis. Non-invasive prenatal testing and diagnosis, what is the difference between both of them? Both depend on the technology of, again, detecting the cell-free fetal DNA and the maternal serum. Okay, so you can see here, this is the mother blood vessel. Okay, and this is the maternal DNA, and the small one here is the fragments of the fetal DNA. So detecting the fetal DNA, okay, can be either a screening test or a diagnostic test. We are detecting the same thing using the same technology. So why in some cases we will call it non-invasive prenatal diagnosis, and why in some cases we will call it non-invasive prenatal testing? Yes, when it gives you a definitive answer, it's called diagnostic test. What definite answer it can give you? Simply, if you are not sure about the baby sex, why you are searching for the baby sex? Because the woman wants to buy new clothes for the baby? Of course, no. It's because the woman is at risk, or the baby, the unborn baby, is at risk of one of the hereditary conditions or genetic disorder that, being a boy or a girl, is very important to determine the risk. Like which cases? Yes, excellent. Hemophilia. Yes, excellent. So, mother, she's X. If they have found a fragment of a DNA that contain XY, that means she carries a boy or a girl. That means she carried a boy. Yes, excellent. So if the mother, her blood group is O negative, then they have fragments of the DNA that contain, for example, A positive for the blood group, or the Rh factor is positive. That means she carry a baby with a positive blood group. That means her baby would be at risk of what? Yes, isoimmunization. Yes. So, sometimes, in some conditions, for some reasons, it can give you a definitive answer. It can give you yes or no answer to your question. Okay? In some other condition, it will give you a very, high possibilities, and it will be accurate, like 99% in cases of trisomy 21, but still not a definitive answer. It's called non-invasive prenatal testing in this case. Can we use non-invasive prenatal testing for all conditions? Of course, no, we cannot. It cannot give you answer for everything. Yes, it's a very good technology, okay? And it's used in some conditions like the baby diagnosis, the baby 6, or the resuscitation status, or some monogenic disorder, okay? For also aneuploidy, non-invasive prenatal testing, this is its role in detecting aneuploidy, but it's not for everything. Monogenic disorder, it's a monogenic disorder. So if the gene is found, means that the baby is affected, right? So it will be a non-invasive prenatal diagnosis. The term non-invasive prenatal testing used for using the cell-free fetal DNA technology to test for aneuploidy. No, it's not a definitive answer, Dr. Kausar. It's still 99%. So it is not a yes or no. It's yes, high sensitivity, high prediction, but it's not yes or no. Still, there is a chance. There is 1%. So, guys, some information about the non-invasive prenatal testing still can come in your exam. Okay, so we said non-invasive prenatal testing used cell-free fetal DNA to test for aneuploidy, right? So we are now with the NIPT. As opposed to the non-invasive prenatal diagnosis, which uses the cell-free fetal DNA to diagnose fetal sex or RDH status. Okay, so non-invasive prenatal testing, screening test, and need confirmatory invasive testing in cases of high risk means positive result. Okay, so again, guys, clearing the concept, non-invasive prenatal testing is a screening test, and it's need confirmatory invasive testing to confirm the diagnosis. It shows high sensitivity, and specifically for trisomy 21. It is little bit less sensitive in other conditions like trisomy 13 or 18. And this table is another table from the TUG article that show you, okay, when you compare its detection for trisomy 21, it was 99%, okay, even higher. When it is used for detection of trisomy 18, it was almost 97%. For the trisomy 13, it was even less, okay? It was like 90%. So guys, if the question comes and asks you about the sensitivity of NIPT in aneuploidy screening is higher for which condition, and give you in the choices trisomy 21, trisomy 18, trisomy 13, monosomy X. Yes, it's for trisomy 21. Is it a possible question in exam? Yes, it's a recall question. Okay. The question comes, another question. Twin pregnancy. Can you use non-invasive prenatal testing in cases of twin pregnancy? No, not advised, according to both RCUG or ACUG as well. Okay. So how many days this test need to come out with the result? 3 to 5 days. 3 to 5 days the result can come up. Okay, so is that test without errors or a disadvantage? Of course, no. There is no such thing. Always we will have some errors in the test. And the errors is different, guys, from the detection rate or the sensitivity or specificity. Okay, errors, that's mean it's error in the technique, in applying the technique. Okay, so what are the possible causes of these errors? Actually, we have found that inconclusive result rate is from 1.9 to 6%. So the most common cases reported in a false result was low fetal DNA fraction. Why you will have a low fetal DNA fraction? What do you think? If we do it very early, okay, that's why the recommended time, okay, for that test is yes, it's the 10 weeks. Excellent. And it will be washed from the maternal, it's a pregnancy specific test. So once the baby is born, the fetal DNA of the baby will be washed out from the maternal circulation in few hours. Okay, so this is a test also to be done only during the antenatal period. Okay, so the most common cause of we have wrong or errors in the result is they will do the test very early. Okay, another single best answer question. Okay, in cases of vanishing twin, the test is not accurate. Okay, so when one of the twins disappeared prior to the woman dating ultrasound scan, okay, which if it was non-identical twin, it will cause a false positive result. Why? Because simply there is two DNAs are there. One for the twin that had died, vanished, and one for the current living one. So vanishing twin is one of the causes of error. Again, When we will advise to do the test, what is the gestational age when we advise doing the test? 10 weeks. Yes, excellent. Another causes. Can anybody tell me other causes why we could have error in the test? Yes, when we have confined placental mosaicism. Okay, so this is a condition that will cause as well error in the test. Another error in the result can be cause maternal cancer. Okay, and high maternal BMI. Excellent. Yes, this is another cause. So guys, it is not like a magic test. Still, we face some errors and limitation with using the test. There is two articles regarding the non-invasive prenatal diagnosis or Down syndrome evolution in the diagnosis. Okay, but I will advise you read the TOG articles, but don't take the algorithm from the TOG article. Okay, because it is different from the NICE guideline, and when we have TOG article and the NICE guideline, which one we will apply in exam? We will apply the guideline. Yes. And when we have different between NICE and GTG, Green Top Guideline, which one we will apply? Yes, it is the GTG. Excellent. Okay, guys, so what do you think? Can we go back to our antenatal care for the NICE guideline? Yes, let's go. So guys, we have stopped at the period of the first trimester and offering the woman the scan between 11 plus 2 to 14 plus 1 weeks. Okay, then what's the next after this period? If there is anything routinely we will advise, yes, of course. We will offer the pregnant woman ultrasound scan between 18 weeks of gestation and 20 weeks plus 6, or I would say from 18 to 21 to make it easy. This ultrasound scan aiming for screening for the fetal anomalies, the major anomalies, or determine a placental location. Both will be done at this time, okay, the 20 weeks scan, which is called as anomaly scan, okay, and this is the most important scan actually, okay, we will advise for. For a pregnant woman who has been identified, you remember we have tested the woman for the blood group and the RH. If you find that the woman has RH negative, when you will offer her the prophylactic doses? Yes, both regimen are acceptable, either to give one dose, okay, at the 28, or to give divided doses, okay, between the 28 and 34. So both regimen are acceptable. Will you repeat again the full blood count and blood group and antibody at the 28 weeks? Yes, we will repeat it again. Okay, so this is a routine thing. So we should know what's offered in the routine antenatal care for all pregnant women in the UK, right? Okay, guys, so now this is the routine thing we offer to everyone. Then I will go to identifying high-risk women. But before I go, may I ask you a question, guys? Can we start the Down syndrome screening by the non-invasive prenatal testing right away for all pregnant women? No. Why no? Looks like a good test to give us result. Why no? Expensive. That's it. Okay. So it's not about accurate or not, it's expensive. Still, even if it is the NHS funding, okay, the NHS will go, you know, with the limited funding they have. They can't offer expensive test as a screening test for all pregnant women. They start, guys, the normal, the routine, starting by the combined and the quadruple. Still, this is the practice. They wish, okay, so the doctors wish to go for the non-invasive prenatal testing first, especially if the woman is a high risk, okay, but actually this is not the offered one. Only NHS will offer for a low risk woman or for the routine antenatal testing is a combined test and the quadruple test according to the gestational age. Okay, guys, so I'm going with you to identifying women at risk. Do you remember when we speak about the booking visit? And at the booking visit, we will identify the ladies with high risk for some conditions. So we will refer them appropriately. Okay. Of course, if the woman has a medical disease from the start, like a woman known to be hypertensive, a woman known to be diabetic, a woman known to be having any other chronic disease, she will be referred to the high risk pregnancy unit right away. But there is some condition that we need to screen for and identify which woman can develop this complication of pregnancy. Okay, so like what? Like preeclampsia, like diabetes, like small for gestational age. Okay, so we identify the women who are at risk of having pregnancy complications. Okay, so this will be identified only by history. So first thing, identifying preeclampsia. The question here, when you will offer measuring blood pressure and urine test for proteinuria to pregnant women? At every visit. Yes, excellent, guys. At every face-to-face visit. Okay, so we measure and record the woman blood pressure and urine dipstick test for proteinuria at every routine face-to-face antenatal appointment. Okay, so this is when we offer blood pressure measuring and test for proteinuria. If at any point you find during the antenatal care that the woman have blood pressure and she is beyond the 20 week, okay, below 20 week means that she is hypertensive but not discovered. This is another pathway. Okay, but we speak here about the beyond the 20 week, means it's a complication of pregnancy. So beyond the 20 weeks, if you have blood pressure measured 140/90, means that you need to refer the woman to the secondary care for assessment. Okay, not for admission, for assessment. So 140/90 means she would need to be seen in the secondary care within how many hours? Within 24 hours. Excellent. So if the woman during the antenatal care after 20 weeks, while the nurse is measuring her blood pressure, found to be 160/110, then this will be urgent referral in the same day, in the same time. We will refer them to the secondary care. And in the secondary care, they will admit them and do what is necessary according to the hypertension guideline. Okay? So One within 24 hours and the other one is urgent in the same day. Within 24 hours means that if you are like now, okay, it's now 3:30 p.m. in the UK, so I can tell the woman, okay, so you can go tomorrow morning to the hospital, right? To the secondary care. But if I find that her blood pressure is 160 over 110, I will send her now, right? So this is different. Between within 24 hours is different than urgent referral in the same day, right? One will be referred for assessment and the other one will be referred for admission. So we will discuss in details in the hypertension guideline what are the steps to be taken, what are the investigation and everything. But here, guys, we speak about identifying the risk. Still, the woman, she didn't develop anything. Okay, woman with previous risk factor. Okay, so what you will do, we identify the woman to be a high risk for hypertension if she had previous hypertension in pregnancy, chronic kidney disease currently, or she had autoimmune disease like systemic lupus, or she is diabetic, known to be diabetic. That's mean she will be at high risk of preeclampsia. Okay, or even the woman who has chronic hypertension is a high risk for preeclampsia, superimposed preeclampsia. Okay, so what we will do for those ladies who have one of these high risk factors, yes, we offer them aspirin from 12 weeks until delivery. Okay, so what is the dose of the aspirin? According to the BMI. If the BMI is high, we will offer the 150 dose. If the BMI is normal, we will offer the 75 dose. Okay, guys? So this is the management for prophylaxis, okay, or reducing the risk of preeclampsia in high risk women, the women who are identified as a high risk. There is another risk, but it's not identified as high, it's only identified as a moderate. Okay, so if the woman has two of this moderate risk, okay, we will start with her the aspirin from 12 weeks till delivery of the baby. What are the moderate risk? The moderate risk are either first pregnancy, means the woman is preemie, age 40 or even older, pregnancy interval from the previous one is 10 years, body mass index of 35, okay, or more, family history of preeclampsia, not herself, one of the family, or twin pregnancy. So twin pregnancy is identified as a moderate risk, right? So if you have a preemie and she had IVF treatment and she had twin now, will you advise her aspirin from 12 weeks? Yes, sure. So what if you have a multiparous, but her age is 40 years and her BMI is 35? Yes, you will start the aspirin from the 12 weeks. There is another condition that we screen for from the history of the patient, which is the small for gestational age. Risk that this woman can give us a baby with small for gestational age, with one of the complications of pregnancy, right? So we have major risk factors first. We need to go for it. Major risk factor like maternal age, when it is more than 40. Or if the woman is a smoker, more than 11 equal or more than 11 cigarettes per day. If the woman herself or her husband or partner was a small for gestational age. Cocaine abuse. is a small for gestational age risk. Daily vigorous exercise. Previous small for gestational age baby, which is the most common risk, comes in exam. Maternal small for gestational age. Chronic hypertension. Diabetes with vascular disease. Renal impairment. Antiphospholipid syndrome. Heavy bleeding similar to menses. Or measurement of the PAPA-A, the pregnancy associated plasma protein, is less than 0.5 of MOM. So this is a major risk factor for what condition? For the small for gestational age. What is the action to be taken? At the level of the antenatal care, it's 16, start the aspirin by 16 weeks. What if the woman found to have high risk for preeclampsia and at the same time high risk for small for gestational age? Of course, we will start the aspirin early, right? Okay. What are the next step? The Doppler ultrasound according to the GTG, which will come in details in the next sessions, a serial gross scan. There is minor risk factors. Yes, there is minor risk factor for small for gestational age. 3 of these will give us high risk patient of the minor risk factor. Give me examples of a minor risk factor. I will tell you. Maternal age 35 or more. IVF, single tone pregnancy, is a minor risk factor for small for gestational age. Nulliparity, BMI less than 20, BMI between 25 to 35. Smoker, but cigarettes 10 or less per day. Low fruit intake, previous preeclampsia, pregnancy interval less than 6 months, pregnancy interval 60 months means 5 years or more. Those are minor risk factors for small for gestational age. You will have to look for the small for gestational age risk factor and hypertension risk factor, diabetes risk factors, and VTE risk factors. Okay, sounds like scary if you study them for the first time, but I have given you all of them in one file. Okay, so you have a look, guys, for all of the risk factors and compare between them. And by reviewing those algorithms many times, okay, believe me, you will have it by heart. You will keep it by heart. It will be like your name. But revise them. There is no way to remember them without repeated revisions. Okay? Thank you very much, Dr. Nairuz. So guys, for the antenatal assessment of the VTE, this is as a very big guideline, okay? And we will revise it in time, but at least I will tell you that we divide the ladies into low risk and the women who are at lower risk of VTE. We will advise them mobilization and avoidance of dehydration because pregnancy itself carry the risk of VTE, but they don't have background risk. They are at lower risk. They are healthy. Okay, so healthy women, low risk for VTE, advise them mobilization and avoidance of dehydration. Okay, so even if the woman is low risk, still need advice. Okay, there is intermediate risk. Okay, intermediate risk, that's mean we will offer them antenatal prophylaxis, okay, of low molecular weight heparin. There is a woman identified as a high risk, which we will start for them low molecular weight heparin from the start of pregnancy, and we will refer them to the hematologist. Okay, some of them will be identified even as very high risk, and if the woman is identified as very high risk, that's mean she will have a high dose prophylactic low molecular weight heparin. Okay, you don't need to study this part in the antenatal, just know that there is risk assessment would be offered to all pregnant women at booking and repeated again in the second trimester. Okay. And according to the risk, you will identify or you will decide to start low molecular weight heparin or not. Okay. Gestational diabetes. The gestational diabetes, little bit trick there. Okay. Identifying the woman at risk during the antenatal care. If the woman has a BMI of 30 or she had previous big baby, weight more than 4.5 kilogram, previous gestational diabetes, family history of diabetes, okay, or ethnicity with high prevalence of diabetes, okay. So those women, okay, will be having referral for oral glucose tolerance test that will be between 24 and 28 weeks. The question here, which woman will have the OGTT at booking, and if it is okay, still we will repeat it between 24 and 28. Yes, the woman with the previous condition. And you know that the highest risk for any condition is a previous history of the same condition. So the highest risk for gestational diabetes is a woman with previous history of gestational diabetes. So what we will offer her, is either early self-monitoring of blood glucose or 75-gram 2-hour OGTT as soon as possible after booking, okay? And then if it is normal, we will repeat it again between 24 to 28 weeks, okay? Of course, if it's abnormal now, it will be identified as diabetic and she will go to the pathway of diabetes in pregnancy. But if it is normal in the first one, we will repeat it again. Okay, so the difference here, because it's very easy, so even candidate will mix them, will mix the risk factors of the gestational diabetes and what is the step to be done for any woman identified as having risk for diabetes or the woman identified as previous history of gestational diabetes. This is different. Okay, guys? So this is for the diabetes. Of course, we have a big guideline for the diabetes, but it's worth mentioning that this is included in identifying risk in routine antenatal care. So it must be included in this guideline when you study it. The guideline is still discussing other common problems that arise in pregnancy and how are you going to solve them. So Dr. Rabaa, BMI is the booking weight, okay? So if the woman presented at booking, we will take this BMI and we will keep using this BMI in identifying any other risk. No GDM, dear, okay, is a complication of pregnancy that also towards, you know, the second and third trimester, the blood glucose will be arise. If the woman comes at booking and you found at booking that she had high blood sugar or the OGTT is high, that means she is a diabetic but unknown to us, undiagnosed. Okay, so in this case we will do hemoglobin A1C to have an idea about her blood sugar level in the previous 3 months. But we will not accept women at booking with high blood sugar. This is not a complication of pregnancy. This is a condition she came with. Dr. Omnia, retinopathy is not here, is not an identifying risk of gestational diabetes. We will screen for retinopathy in women with diabetes mellitus disease, either type 1 or type 2. Okay? But retinopathy is not a routine test in antenatal care. Yes, if the woman, she is diabetic, either type 1 or type 2, non-diabetic, and she come for booking, this is a high-risk pregnancy. So we will look for her general condition. We will even look to the renal function test and the retina screening. Okay, so the woman will be referred if she didn't have a recent one. That will be in details in the diabetes mellitus guideline. Diabetes in pregnancy. Okay, guys, so moving to the common problems. And the common problems is very easy, so it will be a good end for our discussion today. The common problems arise in pregnancy is, I would say, most commonly nausea and vomiting, right? So if the woman presented with vomiting in pregnancy, what you will do? If it is a mild to moderate nausea and vomiting, reassure her that this is going to improve, okay, between 16 to 20 weeks. She can try, some diet modification and use ginger. And ginger now came in the guideline, okay? So it can be an exam question, okay? Ask you about a woman with mild to moderate vomiting in pregnancy. So mild to moderate vomiting, you will not start the drug treatment, okay? You will advise dietary modification and ginger. Try ginger. Guys, am I audible to you?
Yes.
Okay, thank you. Thank you very much. Okay, guys, so if it is severe vomiting in pregnancy, then here I will advise you to skip the information in the antenatal care guideline, okay, the NICE guideline, and return back to the GTG. Because in the GTG, the questions comes from there and it's more organized. The information are more organized, okay? So the GTG will be applied here. You will, according to the PUC score, okay, if the woman had mild to moderate or severe, you will start, okay, the treatment as recommended. For the drug treatment, first line, what is the name of the drug first line? Cyclizine 50 per oral or IM or IV 8 hourly. Or chlorabazine 5 to 10, 6 to 8 hourly, okay? Or increasing the dose if it's given IM or IV. Promethazine is one of the choices, or chloropamazine as well. Second line is methyl-chloropramide. It's widely used in pregnancy, and the maximum duration to be used is 5 days. Remember the most common complication related to the use of methyl-chloropramide in pregnancy, okay, which is called, yes, extrapyramidal manifestations. Domperidone is still used as well and has a good result as well. So 10 mg 8 hourly. For the ondansetron, there is a safety, okay, issue regarding the use of it and its relation to congenital malformation. So please try to avoid this answer in exam, okay? Ondansetron has some safety issues about its relation to congenital malformation, so try to avoid it. okay? And the safety issues has been published, okay, after the GTG, so that's why it's not mentioned here. The third line in the management is you can here start steroid, and the steroid starting by the hydrocortisone 100 mg twice daily IV, and once the woman has a clinical improvement, you can convert it to prednisolone, okay, daily 40 to 50 mg per oral, then reduce the dose gradually, okay, till you maintain lowest effective dose. Okay, guys? Domperidone is still used here. It's widely used. I have shared with you guys a guideline. So for anyone who's interested in reading all the details of the antenatal care, even including the safety concern or some comparison between the medications, it will be found in the NICE guidelines, the original version of it. Okay, guys, so coming to another common problems that appears in pregnancy. If a woman had heartburn, what you will advise? Simply, it's dietary modification, right? Changes. Consider a trial of antacids, okay? Simply. If the woman has pelvic girdle pain, advise some exercise or non-rigid lumbopelvic belt, okay? So it's exercise or using the non-rigid belt. I'm going back now to the bleeding, the unexplained bleeding. Okay, so this is not related to any pathology identified, just a woman presented with some unexplained vaginal bleeding after 13 weeks. What is the management of this lady? First, question number one, do you think that woman is almost in the second trimester and she presented with bleeding? You think she need anti-D if she is Rh negative? Yes, so anti-D would be advised for all Rh negative women who presented with unexplained vaginal bleeding after 13 weeks. Okay. Try to exclude, okay, the woman will be admitted, assessed and admitted to the hospital, okay, and exclude the diagnosis of antepartum hemorrhage and exclude preterm delivery, okay, and assess the extent of this vaginal bleeding, and if it is severe, okay, so we may even terminate the pregnancy, resuscitate the woman first, then terminate the pregnancy if it is severe, uncontrolled. Okay, so let's say a woman presented with unexplained bleeding during pregnancy, and he give you steps and ask you to rearrange it. So the steps are BV examination, speculum examination, ultrasound, localization of the placenta, or resuscitation, or assessment of vitals. So what is the first one? Vital signs, excellent. Assessment of vital signs, excellent. If the woman has low blood pressure or she's unstable, then resuscitation will come. Okay, now ultrasound is not after the speculum, is not before, sorry, the speculum examination. BV is not advised in cases of unexplained vaginal bleeding, BV examination. But the first reaction, you can insert the speculum and have a look by your eyes, okay? Then do assessment Yes, maybe in preterm labor, maybe a cervical polyp, right? So the first thing is assessment of vitals. Okay, exclude abdominal examination that there is tenderness or abruption or anything. If you go to the vaginal examination, this will be only speculum, sterile speculum examination. Have a look. Okay. Then advise to do the ultrasound for the placenta localization. You want to make sure that the placenta is not covering the os or very low or anything. Okay. Then if no low-lying placenta, then you can do the rest of your examination. Okay, so it's very important that you exclude the low-lying placenta. Okay, ABC, resuscitation and vitals always first, then assess the placenta. Okay, if it is a low-lying or not. Okay, so for the woman who's low risk for small for gestational age, how we will monitor the fetal growth and well-being, because it's not advised to do ultrasound in the third trimester for the low-risk patient. We don't routinely offer ultrasound for low-risk patient. So how are you going to monitor the fetal growth? Yes, by measuring the fundal height. Yes, and if the woman found to have large baby by the examination, then consider ultrasound scan for the fetal growth and well-being. While if the woman found to have small baby, that's mean what you will do. For small for gestational age, guideline applies here. So you will refer the woman for a scan and Doppler. Right? Okay, guys. So this is the end of our discussion today. Okay. Thank you very much for attending. Yeah, and hopefully that you find it useful and discuss, or sorry, revise the antenatal guideline, guys, today, and the Down syndrome screening. If you have any question, please don't hesitate to post it in the group. Okay, and see you in the next session. Thank you.